Good evening, everyone, and thanks for joining us for this virtual event on advances in breast cancer screening, risk assessment, and treatment. My name is Dr. Jill Oxley. I'm a breast surgeon and director of breast care for Cape Cod Healthcare. And so tonight we're going to cover a few topics. We're going to talk about why is screening important, review some of the latest data on breast cancer, talk about updated guidelines for screening, what it means to really have a breast cancer risk assessment, and just a brief overview of current breast cancer treatment. So for 2025, the American Cancer Society estimates that a little over 2 million new cancer cases will be diagnosed this year in the United States. Prostate cancer is the most commonly diagnosed cancer among males at 30%, followed by lung cancer and colorectal cancers. Among females, breast cancer continues to be the most commonly diagnosed cancer at 32%, lung cancer at 12%, and colon at 7%. So the lifetime risk of being diagnosed with breast cancer is just over 13%, which means 1 in 8 women will be diagnosed with invasive breast cancer during her lifetime. In addition, the American Cancer Society estimates that over 59,000 new cases of non-invasive breast cancer or ductal carcinoma in situ will be diagnosed this year. So of that 2 million cases, about 44,000 cancer cases will be diagnosed in Massachusetts, and breast cancer is the most commonly diagnosed breast cancer in our state, at over 7,200 cases being expected to be diagnosed this year, followed by prostate cancer, lung cancer, and colorectal cancer. And cancer continues to be the second leading cause of death in the United States, and is actually the leading cause of death among people younger than age 85. For this year, the American Cancer Society estimates over 618,000 people will die from cancer. Lung cancer is the leading cause of cancer death among men, followed by prostate and colorectal cancer. And among women, breast cancer is the second leading cause of cancer death after lung, but higher than pancreatic cancer. And so what that means is that about 2% of women, or 1 in 43, will die from cancer, from breast cancer. In Massachusetts, we expect over 12,000 cancer-related deaths this year, with female breast being number 4, behind lung, pancreas, and colorectal cancer, but actually tied with prostate cancer. But fortunately, death rates are low. In fact, for the most available 5-year period data from 2018 to 2022, death rates in the U.S. are just about 19 women per 100,000. But Massachusetts actually has the lowest death rate in the U.S. at 15.2 per 100,000, and Barnstable County is just a little below that at 14. The death rate overall from breast cancer has decreased 44% since 1989, and the rate of decrease has slowed slightly, though, from 1.9% per year down to 1.2% per year. A lot of this decrease in death has been due to earlier stage disease, because a lot of this decrease coincided with increased uptake in breast cancer screening. But things have leveled off because the rates of screening have basically stabilized as well. But the risk of death from breast cancer remains higher in Black women in every age group except between 75 and 79, and is actually 38% higher than white women, and nearly double the risk for Asian American and Pacific Islanders. So when we're talking about screening, that's what we call it secondary prevention. So primary prevention deals with modifiable risk factors. Secondary prevention deals with screening. So mammography saves lives. Mammograms are the only test shown to reduce deaths from breast cancer in over 9 randomized controlled trials. 3D mammography, or digital breast tomosynthesis, has been shown to detect more cancers and recall fewer patients than 2D digital mammography. And this 3D imaging can be especially helpful in women with dense breast tissue. So out of every 100 women who get a screening mammogram, 90 will be told their mammograms are normal. 10 will be asked to return for additional imaging, like more mammographic views or an ultrasound. But of those 10, 6 will then be reassured that their mammograms were normal. 2 will be asked to return in 6 months for a follow-up exam, and only 2 will be recommended to have a needle biopsy. Getting screening mammograms between ages of 40 and 84 reduces the risk of dying from breast cancer by 40%. And 18%, or nearly 1 in 5 breast cancers, are diagnosed in women younger than age 50. And while this is less than 15% for white women, over 20% of women are diagnosed under age 50 for other ethnic groups, 21% in Black women, and 28% in Hispanic women, 29% in Asian American and Pacific Islanders. 75% of women who develop breast cancer are considered average risk. And as we saw in the last slide, the risk of needing a needle biopsy is about 2%, and the risk of needing a needle biopsy of a benign lesion is only about 1% per year. And some more facts about screening. Well, the risk of developing breast cancer continues to increase with age into the 70s, but the risk of death continues to increase into the 80s. But screen-detected breast cancers are usually more favorable. 2/3 of all invasive breast cancers are limited to the breast at the time of diagnosis, and over 90% have not spread beyond the lymph nodes in the underarm or axilla. And survival from breast cancer is highly dependent on the stage at diagnosis. So epidemiologic data looks at 5-year survival in 3 categories as opposed to our traditional staging. But if we're talking about breast cancer that is limited to the breast at diagnosis, then survival from that is greater than 99%. Regional disease, or cancer that's limited to the breast and the lymph nodes, has 87% 5-year survival. But if a cancer is diagnosed at the time it has already spread to other body parts or metastatic disease, then that survival decreases significantly, down to 32%. The Behavioral Risk Factor Surveillance System, which is sponsored by the Centers for Disease Control, reports the rates of screening in the U.S. 70.2% of U.S. women aged 40 and older have had a mammogram in the last 2 years. This ranges from a low of 59.5% in Wyoming to a high of 78.4% in Rhode Island. In Massachusetts, we have screening at 77%, which is number 3, and 71.9% in Barnstable County. But why are they looking at every 2 years when most guidelines are every year? The American College of Radiology and Society of Breast Imaging updated their guidelines in 2017. The American Society of Breast Surgeons updated their guidelines in 2019 to all recommend that women have annual screening mammograms starting at age 40. National Comprehensive Cancer Network follows these guidelines as well, but the U.S. Preventive Services Task Force still only recommends screening every other year, but that's the only major group that does that. Fortunately, the task force updated their guidelines last year to say that women who are at average risk of breast cancer should begin screening at age 40, lowering this from age 50. So all major organizations now recommend beginning screening at age 40 for women who are at average risk. But all these major organizations also recommend that women have a formal risk assessment by age 25 or no later than age 30. Because without a risk assessment, how is someone going to know if she's at average risk of developing breast cancer or at high risk of developing breast cancer? And how does breast density factor in? Well, all states now require reporting of information about breast density. Connecticut was first in 2009. In Massachusetts, it became a requirement in 2015. In 2019, the Department of Health and Human Services and the FDA changed the Mammography Quality Standards Act to include reporting of dense breast tissue. And just over a year ago, September 10, 2024, mammography facilities were required to provide a breast density notification statement. And women with dense breast tissue may benefit from supplemental screening. Why does dense breast tissue matter? Well, dense breast tissue may increase the risk of breast cancer, especially in postmenopausal women. But for anyone with dense breasts, the cancer may be harder to see on a mammogram, but 3D mammography does have increased sensitivity or is better able to detect cancers than 2D. And supplemental screening with ultrasound or MRI can be beneficial in women with dense breasts. However, these studies do have what we call false positives, meaning they're more likely to detect things that are not cancer. MRI is available for screening for women who are at increased risk of developing breast cancer. And roughly half of U.S. women have dense and half don't. Radiologists categorize breast density in 4 levels, with roughly 10% of women having the least dense category, 40% having the next 2, and only 10% of women having what's considered extremely dense breast tissue. So in order to calculate risk, there's different models available. The National Cancer Institute has the breast cancer risk assessment tool known as the Gale model. This estimates both 5-year and lifetime risks of developing invasive breast cancer. It includes some characteristics such as a patient's age, onset of menstruation, age of first live birth, any female first-degree relatives with breast cancer, whether or not the woman has had breast biopsies, and whether or not there's any atypia. But it doesn't include what we call lobular carcinoma in situ, which is considered a high-risk lesion. It doesn't include male relatives, any paternal history, or any relatives with ovarian cancer. And this may underestimate the risk in Black or Hispanic women. But this number can be useful to determine if someone's a candidate for chemoprophylaxis if their 5-year risk is greater than 1.7%. The Klaus model is another available calculator. It's not widely used. It doesn't have nearly as much data. It only inputs the patient's age, but it does include second-degree relatives as well as first-degree and their ages at diagnosis. BRCA Pro is another risk assessment model that's available. In addition to age, it includes any Ashkenazi Jewish heritage, but no other personal factors. It does include a more extensive family cancer history, whether or not the woman has had any risk-reducing surgeries or prior testing for gene mutations in the BRCA1 and BRCA2 genes. It could determine the likelihood of having a BRCA1 or 2 gene mutation and calculates both 5-year and lifetime risks of developing breast or ovarian cancer. The breast and ovarian analysis of disease incidence and carrier estimation algorithm is not widely used at all, but is available. This can be used in women who either have a known BRCA1 or 2 mutation and can also calculate the probability of a BRCA1 or 2 mutation, but is very labor intensive. So we use one of the most robust and widely used models called the Tyrer-Cuzick or IBIS. It includes the woman's age, whether or not there's any Ashkenazi Jewish heritage, body mass index, and the most recent version also includes breast density. We input the age at menarche or onset of menstruation, age at menopause if applicable, age at first live birth, whether or not a woman has used hormone replacement therapy, and the results of any previous breast biopsies, for example, atypia, hyperplasia without atypia, or lobular carcinoma in situ, this high-risk lesion. We can input a family history of breast or ovarian cancer in first, second, and third-degree relatives, including male relatives. And this calculator will estimate the risk of having a BRCA1 or 2 gene mutation and reports 10-year and lifetime risks of developing breast cancer. And if there is a known gene mutation, another calculator called All Syndromes Known to Man Evaluator or asktome.org can calculate the risks of cancers associated with these gene mutations. It was developed by Dr. Hughes when he was at Mass General. We input the patient's age, the known mutation, if she has had any prior cancers or any prophylactic surgery, and the calculator includes guidelines for management when available. And so there are factors that both increase and decrease the risk of developing breast cancer, and not all of these are included in these risk calculators. Elements that increase risk include family history, age, ethnicity or race, and things we can't control. Things we can control, like lifestyle factors, including increased body mass index, alcohol consumption, current or prior use of combination hormone replacement therapy. Reproductive history plays a role. Having a younger age at onset of menstruation, no children, few children, or older age at first live birth also contribute to breast cancer risk, as is having an older age at menopause. And then breast biopsies play a role. Atypical hyperplasia and LCIS are risk factors, but even the number of breast biopsies designed to rule out cancer can play a role in increasing risk. As we said earlier, mammographic density can increase the risk of breast cancer, especially after menopause, and whether or not a woman was exposed to chest or thoracic radiation therapy between the ages of 10 and 30 can increase risk. And there are some elements that decrease risk, although you see this list is a lot shorter, unfortunately, than the other. But going through menopause earlier than age 40 can decrease risk, along with using risk-reducing medications, but also healthy lifestyle choices, such as getting regular exercise, limiting alcohol, maintaining healthy body weight. These all can decrease risk, as can breastfeeding. So when someone comes in for a formal risk assessment, at our clinic, she meets with one of our breast surgeons, our nurse practitioner, or PA. We take a comprehensive personal and family history, including the GYN and reproductive history that we've talked about a minute ago, any breast biopsies. We also perform a clinical breast exam and can facilitate genetic testing when appropriate. And then we determine a personalized plan for follow-up. And this includes imaging, along with clinical breast exams, which are recommended every 6 to 12 months for high-risk women. We review breast awareness along with these lifestyle modifications, and when needed, we can prescribe risk-reducing medications or perform risk-reducing surgeries. So guidelines for high-risk women in part depend on why she is high risk, but we basically follow the screening guidelines established by the American Society of Breast Surgeons. Women age 25 and older should undergo a formal risk assessment for breast cancer, and this is especially true for Black women or women of Ashkenazi Jewish ancestry. A woman should begin screening at age 40 if she is at average risk, and women at higher than average risk should undergo additional supplemental imaging in addition to routine screening. Depending on the reason for high risk, such as a gene mutation or previous chest radiation, a woman can start MRI screening as young as 25 and mammographic screening as young as age 30. And for women who are at high risk of breast cancer by these models or have a strong family history, we recommend having a mammogram once a year and an MRI once a year, ideally spaced at 6-month intervals. And someone who's had a history of breast cancer may benefit from supplemental screening as well if she was diagnosed under the age of 50 or if she has dense breast tissue. And anyone should continue to screen as long as she's in good health, and especially when the life expectancy is still 10 years or more. And according to most recent Social Security Administration data, the average U.S. woman who is currently 79 years old will live another 10 years. So genetic testing may be indicated as well once this risk assessment has been completed. Gene mutations still account for only 5 to 10% of all breast cancer diagnoses, and it is preferable to test someone who's been affected with breast cancer when possible, or other cancers. But we can test people who have not been affected by cancer in certain situations. If there's a known gene mutation, what we call pathogenic or likely pathogenic, in a blood relative, then it may be reasonable to test someone who hasn't had a cancer diagnosis. It also can be considered in someone who's of Ashkenazi Jewish ancestry, even without additional risk factors. Some of these risk models we mentioned, such as Tyrer-Cuzick, can report a likelihood of having a BRCA1 or 2 gene mutation, and therefore if that likelihood is more than 5%, that patient would meet criteria for testing. Or someone who has a first or second degree relative who would otherwise have met criteria for tested could be tested themselves. For example, if that relative was diagnosed with breast cancer under the age of 50, if that relative had a triple negative breast cancer or multiple breast cancers, or if there's a male relative with breast cancer. Risk-reducing medications can be indicated as well. These are now strongly recommended in women who've had a diagnosis of lobular carcinoma in situ, and can be used in women who've had atypical hyperplasia as well. Depending on the drug and the reason for the risk reduction, this can reduce the risk by between 49% and up to 86%. So this should be discussed to women who have an elevated risk score and also women who've had previous chest radiation. If a woman has not gone through menopause yet, then the only drug we have available is tamoxifen, unless she can be enrolled in a clinical trial. Postmenopausal women have a few more drug options. Tamoxifen is still useful, along with raloxifene, especially if there's a need to improve bone density. There's also other drugs called aromatase inhibitors that can be used, and again, potentially clinical trials. And the highest risk women may benefit from risk-reducing surgeries. So risk-reducing mastectomy can be used in women who carry a gene mutation, either pathogenic or likely pathogenic, which increases her likelihood of developing breast cancer. It can be considered if there's also a strong family history, or if the woman received radiation to the chest wall earlier than age 30. It is no longer recommended just due to a history of lobular carcinoma in situ. And of course, as with any surgery, we need to consider the patient's age, life expectancy, and any comorbidities or their medical problems. Because risk-reducing mastectomy does have psychosocial and quality of life aspects as well. But this can reduce the risk of developing breast cancer by greater than 90%, and especially in a woman with a BRCA1 or 2 gene mutation, can potentially improve survival. And just for the last couple of minutes, we'll just review the current state of breast cancer treatment. So there are three main categories of breast cancer treatment: surgery, radiation, and medications. Surgery on the breast is designed to remove the tumor and perform surgical staging of lymph nodes in the underarm or axilla when needed. Radiation therapy is frequently given after breast-conserving surgery and sometimes after mastectomy. And then medical therapy for breast cancer can be divided even further into hormonal therapy, also called endocrine therapy, chemotherapy, target therapies, and immunotherapy. Breast cancer surgery can be what we call breast-conserving surgery or a lumpectomy or a mastectomy. The goal of a lumpectomy is to remove the cancer with a margin of surrounding normal tissue. There are what we call oncoplastic breast surgery techniques. When needed, the goal of oncoplastic breast surgery is to optimize the aesthetic results while maintaining oncologic principles. And this can be broken down further into level 1 techniques when less than 20% of the breast volume needs to be removed, and level 2 techniques when between 20 and 50% of the breast volume needs to be removed. And this can be performed by the breast cancer surgeon and or in combination with a plastic surgeon. Lymph node surgery is part of staging of breast cancer for many women. And for the last 25 years or so, we've performed what we call a sentinel lymph node biopsy as really the standard of care. What this does is let us map the lymphatic system and sample the first few nodes, meaning the ones most likely to have spread of cancer, and avoid a large lymph node surgery for women who do not have disease in the lymph nodes in the underarm. This replaced axillary node dissection as the standard of care for invasive breast cancer. But since then, we've further identify women who don't need more extensive lymph node surgery. Women who are having lumpectomy or breast-conserving surgery can avoid a complete axillary node dissection if less than 3 of their sentinel nodes have breast cancer. And another trial called AMAROS actually compared radiation therapy to completion surgery for women with limited disease in their lymph nodes. When this technique was first used, it did not apply to women having chemotherapy before surgery. Then it was shown to be safe and accurate in women who had chemotherapy before surgery. But now we can also pursue less axillary node surgery in women who had lymph node disease before chemotherapy if their treatment looks to have normalized their lymph nodes. We also can omit lymph node surgery entirely in several women. The Choosing Wisely campaign focused on women over 70 with small hormone-sensitive cancer and who were having breast-conserving surgery, showing no improvement in either outcomes or treatment decisions with surgical staging of the axilla. And the SOUND trial included women down to age 60, showing no benefit from surgical staging of the axilla if those women had normal axillary ultrasounds prior to surgery. And the reason why we don't want to remove more lymph nodes than we have to, or any lymph nodes if we don't have to, is because of lymphedema, which is arm swelling that can result from any lymph node surgery. The risk of developing lymphedema with a sentinel node biopsy is between 5 and 7%, but can be as high as 20 to 25% with the more extensive lymph node surgeries. So we have a lymphedema prevention program here at Cape Cod Healthcare as well, where we follow women for the development of lymphedema before there's any symptoms, what we call subclinical lymphedema, and can refer to our lymphedema therapists. Radiation can be given as well with lumpectomy, but radiation techniques have evolved considerably. The long regimens, 6 or 7 weeks of daily treatments, are hardly ever necessary. Radiation now is given what we call a hypofractionation, which has shortened it to about 3.5 to 4 weeks. There are other treatments that can be as brief as 5 treatments. There's whole breast radiation, and then there's partial breast radiation. But there's also data to support omission of radiation, especially in women over 65 or 70. There were 2 major trials there who had hormone-positive cancers less than 3 centimeters, who had breast-conserving surgery. They did not benefit from radiation in terms of survival as long as they took 5 years of hormone therapy. And the medical therapies that we mentioned earlier for risk reduction are still the mainstay of treatment for breast cancer that has estrogen receptors. This is used in non-invasive breast cancer or ductal carcinoma in situ to reduce the risk of not only the ductal carcinoma in situ returning, but reduce the risk of getting a second breast cancer moving forward. And for women with ER-positive, HER2-negative, node-negative cancers, we have genomic assays that can help determine if women would need chemotherapy in addition to endocrine therapy, or if their benefit is strictly from the endocrine therapy. Oncotype DX is one of those major trials, along with and TAILOR-X. But more recently, the RxPonder trial expanded further identifying women who don't benefit from chemotherapy. Women with between 1 to 3 lymph nodes involved with cancer were involved in this study, and it's identified a patient population with a low risk score who, even though they have limited nodal disease, they still are not going to benefit from chemotherapy. Their benefit will be from hormone therapy. And there's targeted therapies, HER2-positive disease. We have trastuzumab, pertuzumab. These drugs can be given before or after surgery. Kedcycler, TDM1, if residual disease after chemotherapy, and HER2 if metastatic or unresectable disease. Triple-negative breast cancers have medications such as Keytruda for high-risk disease that can again be given before and after surgery. Xeloda can be given after surgery. Lynparza is a targeted immunotherapy for women with BRCA1 or 2 gene mutations. And then these other drugs, they're kind of the ones you see advertised on television. Verzenio, Kisqali for high-risk, hormone receptor-positive, HER2-negative breast cancer. And then there's always clinical trials. That's how we get all this good data. The Riley Family Oncology Research Center at Cape Cod Hospital helps facilitate that. And in 2019, Cape Cod Hospital's Medical Oncology Program became a member of the Dana-Farber Cancer Institute Cancer Care Collaborative. That has allowed us to expand our on-site second opinion clinics, as well as our clinical trials program, and expand participation in tumor conferences and educational opportunities for physicians and nurses. And Cape Cod Healthcare is accredited by the American Cancer Society Commission on Cancer, and both campuses have accreditation by the National Accreditation Program for Breast Centers. So Benjamin Franklin may have said it best: an ounce of prevention is worth a pound in cure. So the more breast cancer we can prevent, the better the outcomes will be. And while you can't actually do a mammogram online, you can schedule your mammogram online at the website listed here, www.capecodhealth.org/breast-care, or via MyChart. Also on the website, you can take a free 5-minute breast health assessment and access other resources. So I think we already have some questions coming in. We have a question: is breast density alone a reason for supplemental screening, or only based on risk assessment greater than 20%? So the answer is it depends. Women with dense breasts may benefit from supplemental screening, but these other studies, such as ultrasound and MRI, can have higher rates of false positive results. So we recommend that anyone, especially with dense breast tissue, have a formal risk assessment to see what imaging she would or would not benefit from. So are men at risk of developing breast cancer? Well, 1% of breast cancers do occur in men, but men would not necessarily need to be screened for breast cancer, but should be aware of their own bodies as we recommend women do. Men would be candidates for genetic testing if there are known gene mutations in the family, or again, unaffected individuals meeting other criteria. Men who have developed breast cancer are more likely to have a gene mutation, but it doesn't necessarily mean that they have one. So we have a question on an age limit. So we don't have an age limit. Again, we recommend that women continue to get screened as long as they are in good health, especially if the life expectancy is still 10 years, which would be definitely into the 70s and potentially into the 80s and even beyond. We're never going to turn someone away who wants a screening mammogram. But certainly someone with a lot of medical problems who wouldn't be able to even undergo a biopsy may not be the best candidate for a routine screening. Is there any risk from the radiation due to mammogram? So the risks from the radiation exposure for a mammogram is very minimal, comparable to a cross-country airplane flight. And again, mammography is the only test shown to have decreased the risk of dying from breast cancer in more than 9 randomized controlled trials. Some to know, if you've had genetic testing, how often should you be retested? So that would depend on when the testing was done and if there have been any changes in either personal or family history that would prompt updated testing. The BRCA mutations are the ones we've known about the longest, but we've had several new mutations identified over the years. So if someone didn't have panel testing done, we would definitely recommend getting that done. Otherwise, if the panel testing was more than 5 to 7 years old, you could be retested. And then the last question, what's the difference between a screening mammogram and a diagnostic mammogram? A screening mammogram is someone doesn't have any complaints. It's been a year since the last one. There's no breast concerns. She goes in, a standard mammogram is 2 views of each breast, and then the report comes in the mail or via MyChart. A diagnostic mammogram is basically everything else, and that can be a follow-up to something else, that can be to evaluate a concern, basically anything other than a routine screening. So I'd like to thank everyone for your attention tonight. For more information or to schedule a mammogram, please visit us on the web at capecodhealth.org/breast-care. Thank you and good night.